My name's Will. I'm a Senior Research Fellow at the Yorkshire Quality and Safety Research Group. And before I introduce our speaker today, I'd like to just go through a couple of housekeeping things, if that's all right. So if you can keep yourself on mute during the presentation. And as you may have just heard, the seminar is being recorded, and a recording will be made available online afterwards. So if there's people you think would like to have been here but couldn't get here, we'd better share that link with them. If you've got questions for our speaker, feel free to put them in the chat, but we should have plenty of time at the end of Chiara's presentation for questions. And that's probably it, I think, isn't it, Sophia, in terms of housekeeping stuff. So without any further delay, I'd like to introduce Chiara, who is an associate professor who leads the Health and Workforce and Systems Research Group in Southampton. She leads a research program to improve health, workforce, well-being and performance, with a specific focus on work hours and workforce configuration and patient safety. So as you will have seen today's seminar, hopefully you will learn about the impact of a variety of staffing and shift work configurations on safety outcomes for patients. So I'll hand over to Chiara, if that's all right.
Well, thank you so much, Will, for the introduction, and thank you so much for inviting me. And I'm gonna start sharing my screen. Also because at the moment I can see myself in front of me and it's quite disturbing. Great. Can you see my screen okay?
Yes, that's fine.
Brilliant, thank you. So yes, as Will was saying, today's seminar is all about shift work and safety outcome for patients. And the way I thought I would structure this is I'm going to start to give you like a broad overview of the kind of theoretical mechanisms that link shift work to patient safety outcomes. And then I'm going to drill into the specific findings from some of our studies. I have been researching this topic for 12 years now, so there's quite a few research studies that I want to take you through. And of course, you know, our studies are not the only studies available on this topic. So I've also included some links on of systematic reviews where you can find even more papers that relate to shift work and patient safety. And at the end, I've actually got some broad questions or points of discussions that I would really like you all to consider. So it's not just a chalk and talk from me, but hopefully at the end there will be plenty of time for dialogue, because I think there's still some very unanswered questions that it would be really worth tackling all together rather than just me talking. So, but without further ado, let's get into the presentation. So just before we start, oh, sorry, I need to make a disclaimer, just because a lot of the research that I'm going to be presenting today was funded by the NIHR and NIHR ARC-Wessex, and I just need to make sure that I tell everyone that actually what I'm going to share today is that of myself and my team, and not necessarily those of the NIHR or the Department of Health and Social Care. So that's been done. And I just wanted to show you very briefly my research group. It's a lovely bunch of people and really talented and very much interdisciplinary. So we have people from sociology, economics, computer sciences, pharmacy, epidemiology, statistics, mathematics, operational research, midwifery, nursing, health services research. So it's a really, really wide range of expertise, and hopefully you will see hints of different disciplines being applied to the research that I'm going to tell you about. So that's them, lovely people. And just to give you, as I said, a brief overview of the theoretical mechanisms that link different aspects of shift work to safety. And I guess also the reason why we started looking at this in the first place. So for example, when we're talking about things like long shift, well, there's that really strong link between 12-hour shifts and fatigue. Here on this graph, you can see that essentially the fatigue on the shift increases at some point after the 8 hours. It starts increasing almost exponentially. So shifts that are longer than 8 hours essentially have an impact on fatigue, and we all know how central fatigue is when it comes to human performance and therefore to patient safety. And with night shifts, we have another layer of complexity, because it's not just the fatigue which is at play, but there's also that circadian rhythm disruption that comes in, which is really, really bad. Because let's not forget, healthcare is a critical thinking and decision-making profession, like really important decisions to be made. And the problem with circadian rhythm disruptions is that these cognitive processes that are regulated by circadian rhythms are disrupted too. And sleep deprivation is another issue, and it affects memory, learning, and task shifting, which is also really crucial in healthcare. And I put out there this study that is still one of my favorite studies, a really well-conducted cohort study that found that the long-term effects of working night shifts are really significant. And so comparing people of the same age, those that have not worked, so those that have worked at least 10 years of night shifts, their cognitive function is equal to those of people who are 6.5 years older. So really impressive results there. But where it all started for us in our research group was more specific looking at these 12-hour shifts, because like night shift, I mean, we knew there was a lot of evidence. I'm not saying that there's nothing more to discover, but I think studying night shifts and patient safety is really well suited in the chronobiology field, or in fields where you have like sleep labs, you can do a lot of experiments. Whereas where I am, we're more like, I would say broadly like health services research. So we don't have access to sleep labs or anything like that. We're more like focused on how the sort of work system works and how it affects outcomes. And we were very worried about the fact that a lot of the assumptions that led to the introduction of 12-hour shifts had not considered that link with fatigue at all. So when 12-hour shifts were introduced a long time ago, so the first studies that we identified were in 1975 in the US. And I've just put up there a photo of one of those studies that basically there were a lot of claims of assumptions that were put forward to introduce 12-hour shifts. And there was things like, of course, work-life balance, you know, people being able to work 3 days rather than 5, and therefore nurses or the health workforce more broadly being happier, finding. But then there was also cost implications because of the reduced overlap between shifts. So it would lead to cost savings in terms of staffing. And I guess the safety angle that I think is really interesting is that of continuity of care. So, and of, you know, having fewer opportunities to miscommunicate at handover. Because of course, when you've got 3 points of handover during the day, it's easier to sort of communicate. But yes, no one seemed to really worry about that fatigue element and how it might come into play. So little by little, we decided to start really looking at these assumptions and checking whether the proposed benefits were actually realized. And so we started with this overarching aim for our research program. So first, we wanted to understand the implications of shift patterns on the work that healthcare staff do, the health and well-being, the patient safety, and the cost and efficiency of healthcare. But then, of course, our ultimate aim was to then start improving healthcare staff schedules to maximize their well-being, job performance, and the quality of care that patients receive. So, of course, but before you start improving, you need to understand how things actually work, because the truth is that there was no robust evaluation of a lot of aspects around shift patterns in the literature. So there were a lot of like service evaluations or pilots of 12-hour shifts where everyone was really happy with them in the first place. And then a few months later, they asked people, oh, what do you think about 12-hour shifts? And everyone was, of course, saying we love them, but no sort of long-term evaluation. And yeah, this is just to say we use a variety of sources. We started with surveys, and I'm going to tell you give you some results from our surveys in a second. And then we moved on to routine data from hospital systems, and that's the later stage of the presentation. So the first step was a cross-sectional survey, RM Forecast. Some of you might be familiar with this survey. It's one of the largest surveys ever conducted in Europe for registered nurses. And so more than 31,000 registered nurses provided information on shift patterns and ratings of quality and safety based on the last work shift. So it was a really big sample. Yeah, with 12 countries, nurses from 12 countries. And what did we find? So first of all, interesting, the shift length. So just looking at the distribution of shift length, bear in mind this was 2013, so more than 12 years ago. But you can see that, I don't know if you're familiar with box plots, by the way, but I'm just going to give you a very basic introduction of how they work. But essentially, if you take, so this, for example, is the UK. So this box here in the middle is the median value of shift length. And you can see that it's somewhere like above 10, but not really 12. And then the upper and lower extreme of the box are the first and third interquartile range. And then there's these points that are essentially the outliers, so values that are really out of the range. But you can see that in most countries, these boxes are quite small, meaning that there wasn't a lot of variation when it comes to shift length. I mean, there was a bit of variation in Spain, but for the UK, there was a lot of variation, right? So you have this median that is actually not a real value, and then really a big spread in terms of 8 or 12-hour shifts. And so that was interesting in and of itself. And it's not like this anymore today. I think today we can say fairly certainly that 12-hour shifts are the norm. But then when we look at the association between long shifts and nurses rating patient safety as poor, we can see that, I mean, it's not really linear, but we can see that the higher the likelihood of a nurse reporting poor safety in their unit. So compared to a nurse who was working 8-hour shifts, a nurse who was working 12-hour shifts was 41% more likely to report poor patient safety rating. And when we came to working overtime, so working beyond your contracted hours, the odds ratio was even higher. So odds increased by 67% compared to someone who wasn't working overtime. So that was really interesting, but we had some more questions. So we knew that, okay, patient safety that seems to be affected. It's nurse reported, so it's got its limitations, but again, more than 30,000 nurses. So interesting, really interesting. And I don't want to bore you with the methodological details, but in these associations, in these models, we were controlling for a lot of other variables that we know influence patient safety. But we also wanted to look a bit more into that assumption that if you reduce the number of handovers, you're going to be improving patient safety, and thanks to, the continuity of care, but also the patient information loss during handover going down. And when again, we looked at the same data set, so again, from RM Forecast, 31,000 nurses, and again, we found the opposite of these assumptions. So we found that actually the amount of patient information lost during handovers went up in 12-hour shifts compared to 8-hour shifts, and the continuity of care went down. So the education ability to engage in educational activities and CPD went down in 12-hour shifts, and the opportunity to discuss patient care with colleagues. And we know how much, for example, CPD and discussing with patient colleagues are how crucial they are for patient safety, because keeping updated with the most up-to-date knowledge also has an impact on patient safety. So 2 studies already that were telling us that it wasn't really looking great. And then, of course, we knew very well that surveys and cross-sectional data have got limitation. Again, not to bore you with the details of endogeneity and which is a type of bias, but it's essentially all about the fact that with surveys and with also cross-sectional surveys in particular, you're more likely to incur in these, specifically in these 3 types of bias. The first one is called common method variance, and it means that when there's one instrument only measuring a lot of different dimensions, like in this case, we had the same survey measuring 12-hour shifts and the patient safety rating and the continuity of care and all the outcomes we were interested in. It can be problematic because essentially you are there's a tendency for a respondent to give either an overall negative response or a positive response. So the person who's working 12-hour shifts maybe be more likely to be reporting everything as negative or everything as positive, if that makes sense. So that's problematic. The simultaneity, again, because you're looking at variables that are occurring at the same time, you cannot really disentangle that temporal effect, or it can be really difficult to establish which comes first. Is it the 12-hour shifts driving safety issues, or is it the other way around? And omitted variables too, of course. That survey was built not specifically to look at shift patterns, so we were not able to measure all of the important variables when it comes to shift patterns and patient safety. So bearing in mind all of these limitations, we started venturing into using routinely collected data from hospital systems, and I'm pretty sure that we were the first in the UK to do that. And it was, I have to say, it was and it still is a painful experience in terms of data access and data cleaning, data management, but it's really worth it because we've been able to look at these relationships in a very granular level and using objective data of what nurses had actually worked, and not just on a one shift only, but on hundreds. Actually, our samples are usually in the regions of a million or 2 million shifts that we can look at. So it's really rich data, very granular, and you can really link the patient outcomes to the shift that nurses have worked. So you can have a kind of epidemiological approach where you can determine what patients are exposed to before they experience the adverse events. And of course, this is crucial when you're looking for causality, cause and effect. And therefore, I mean, a step to that is to find a longitudinal association first. And for shift patterns, we've used data from the e-rosters, so the rosters that nurses actually worked, and NHSP, like bank shifts, so extra hours that nurses worked. And in terms of patient data, we were able to extract patient incidents and vital signs observations, so like compliance with vital signs observations. So vital signs paper, and this was part of my PhD actually, and we looked at the association between the shift patterns that nurses were working in a ward on a day and the likelihood of, on that same day and that same ward, of observations, vital signs observations being missed or delayed. And we found that observations were more likely to be delayed a higher portion of the hours worked by assistants were after long shifts. So we didn't find that for registered nurses. We only found it for healthcare assistants. But we knew in that particular setting, observations were done mostly by healthcare assistants. So that trust was one of the first to move to sort of create a framework that enabled healthcare assistants to do vital signs rather than registered nurses. Of course, again, this for us wasn't enough. I mean, that's what we had for that study, but for us it wasn't enough because, well, it was a single hospital. I mean, great to start somewhere, you have to start somewhere, but it was one single hospital, and so generalizability was going to be an issue. And also vital signs monitoring and compliance with vital signs is not in itself a patient outcome, is like a process. And we believed, of course, that there's a link between, you know, monitoring of patients and then patient deterioration likely going unnoticed. So of course there's a theoretical link there, but it wasn't a hard kind of patient outcome. And of course observations might be delayed for reasons that are not performance related. We've just actually published a study led by Dr. Joe Hope, where we found that nurses or healthcare assistants delay or move vital signs observations for reasons they bundle them together, and but there's so many interruptions, so many other factors that get into play. So again, we weren't completely satisfied. I mean, it was, like I said, it was a starting point, but we thought we can do more, and we did. And I'm going to spend a bit more time actually talking about this study in particular because it really is the first I think that looks at this relationship between working long shifts and patient incidents using objective data from more than one hospital. And there's also a QR code if you want to access the paper. So I thought I'd give this a bit more space. So yes, we wanted to look again at the relationship between nursing staff working 12-hour shifts and the rate of patient incidents in inpatient wards only, of course. And this study was, like I said, in two really large hospitals, and we had access to over 4 years of data. We stopped before COVID-19 because we knew that then things were going to be probably skewed by the pandemic, so we stopped just before that. And for each shift, what we extracted from the nursing rosters, we extracted the start and end time of the shift, the date, the location. So, and then we calculated how many hours they worked and whether the shift was filled by a substantive member of staff or an agency or a bank. And in terms of patient incidents, for sensitivity issues, of course, we couldn't get patient incidents at the patient level. So we couldn't get for patient Mr. White, we know that patient Mr. White experienced such and such incident at such and such time of the day. So that was not going to be possible. So we got this type of data aggregated at the ward day level. So for every day on every ward, how many incidents happened, how many beds we had, of course, because in our models, we need to take that into account because otherwise, you might be looking at a lot of incidents happening on one day, but if it's a really large ward, then you're not exactly accounting for that. So we had that too. And then the incident level of harm, and we had the incident type. We didn't have any descriptive notes about the incidents. We just knew how many there were and what type of incidents there were and the level of harm too. And so this is again box plots. You can see I like box plots very much, but basically, again, lots and lots of variation when it comes to the use of 12-hour shifts. But yes, so these were all the wards that we had in the study, and in some wards there was it was clearly like almost only 12-hour shifts, and in some wards there was hardly any. So a lot of variation there. And when it comes to the relationship with incidents, so again, I'll try to make this really digestible for everyone, but we used a type of multi-level modeling, meaning that we were nesting all the observations within wards, because of course we knew that there were incident rates that varied a lot across wards, so we wanted to make sure that we could factor that in. So we clustered all of our observations into wards, and we used a type of multi-level modeling called Poisson regression or negative binomial, depending on the distribution of the data. But essentially, so it was basically looking at what is the likelihood of change, or let's say the risk of change in the incident rate depending on the proportion of 12-hour shifts that are worked on that day on that ward. And because we knew that the relationship between shift length and patient safety isn't linear, we decided to model this using linear first, but then quadratic and cubic effects. And again, don't worry, I'm not gonna bore you with the statistical details, but that's the reason why you see that a lot of these curves are not just linear, but are in trajectories that are a bit more complex than that. So if we look at the first graph here, we see that for all incidents, so no different incident types. Again, it's not a linear relationship, but we can see that increasing the proportion of long shifts increases the risk of incidents, and especially the risk goes up really dramatically when it's more than 80% of the shifts that are worked in that ward on that day are 12-hour shifts. For valence against staff, again, it's a really different shape. So you can see that the risk is never more than 0. So using more 12-hour shifts seems to decrease the risk of violence. But again, at 80%, you've got that upper, like steep upper curve, and it's rising exponentially. It's not above 1 again, but you can still see that dramatic change. For self-harm, it's almost linear. So again, highest risk in the incident rate is again between 80 and 100%. And with threatening behavior, we have a funny relationship where you have basically no risk and then a bit of more risk as the 12-hour shifts increase, and then it goes down. But after that 80%, it goes up again. So I think very different outcomes. So I'm glad that we looked at them differently. But essentially, the overall message is that apart from violence against staff, in all other cases, like using a lot of 12-hour shifts was not conducive to patient safety at all. But in any case, after the 80%, there's really a drop, a steep increase in the risk. And we again could say, we didn't measure staff fatigue, of course, but we did say it's probably due to that. And so yes, I think again we were satisfied, but I mean satisfied with the type of work that we could do. But of course, there's still some limitations for us, and I'm gonna discuss them in a second. I just wanted to tell you very briefly that in parallel to this strand of work on patient safety, we also looked a lot at workforce outcomes like satisfaction, retention, and well-being in terms of burnout and sickness absence. And again, we only found negative associations, excuse me, for 12-hour shifts. And when we tried to look at choice as a potentially moderating effect in the relationship between long shifts and burnout, we found that was no moderating effect. So even if people had chosen to work 12-hour shifts, the likelihood of being burnt out was still higher than people working 8-hour shifts. So what next? And this is really where I'd appreciate a lot discussing with you. So I think one limitation in our study, and I know there's a lot of literature around this, is the fact that yes, patient incidents are in a sense objective data, as in like we just extracted them from hospital systems. We didn't ask nurses to fill in a survey to tell us how good or bad their safety was. But there's a lot of literature around how the quality of patient incident reporting is very variable, very where it's dubious essentially. So should we be trusting results from studies that use patient incident reports? Should we try and improve the quality of recording, or are there any alternatives to patient incident reports that we should be considering when we do research in patient safety? And I'd be really interested in hearing your thoughts. I mean, bear in mind, I know that there might be other more nuanced qualitative methods of collecting this data, but when you're interested in the sort of systems perspective, and you're working with like big data that you extract from hospital systems, what else could we be using? So that's question number one, or let's say reflection point number one. And then the second one is about addressing staff fatigue. Of course, that's where we are trying to lead the next phase of our research, because we are very aware that that's the link to everything that could go wrong. Not everything, but a lot of aspects that could lead to performance impairments are due to fatigue. But there's an issue that in healthcare we're currently not really measuring, or let alone managing fatigue. And I think, in terms of addressing it, there's different avenues that we should be exploring. So I think it should be, first of all, framed as a shared responsibility. So both the employer and the employee, in the sense that the employee should know about what causes fatigue. And also there's quite a few training packages that have to do with sleep hygiene, sleep training for shift workers in particular. So it's really good if we can help people know more about the risks and how to manage the risks around shift work. But on the other hand, the employer as well need to be able to offer work conditions that are not, increasing or making the fatigue of a risk of people increase substantially. And also it should be okay for the employee to say that they are fatigued. In other industries, for example, it's normal, like to say I cannot come into work because I'm too fatigued, and I'm talking about safety critical industries, of course. But in healthcare, for some reason, this is not acceptable at all, and it's still not treated as a safety critical industry as it actually is. And I think in nursing particularly, there's this super nurse culture that is very alive and kicking. And again, as an academic working also with students and future healthcare professionals of the future, I teach these a lot, and I try and kind of deconstruct completely that culture. Because it's really dangerous, but essentially nurses see themselves as these kind of superheroes that never need a break and never should be asking for help or saying that they're tired. And that's really dangerous because, because basically it means that they're not aware of the risks of working when fatigued. And then with some colleagues in the US, we were thinking about how we rely a lot on ambient data and like in my studies, routinely collected data that are available really easily. And it could be so interesting to triangulate them in different ways. For example, either individual data like wearables or sleep diaries, triangulating them to find out, for example, how at risk of fatigue a person is. And this is just something we put together to describe like a work systems analysis to address fatigue. But again, I think a systems perspective is really needed if we want to address these issues when it comes to shift work and fatigue, and therefore then patient safety. And then the fact that there's lots of addressing conflicting priorities in healthcare. And this is from a paper that is currently under review, so still not in the public domain yet. So you're the first to hear this. But essentially we did interviews with nurse managers, nurses, hospital directors, and patients around priorities for shift patterns. And it's so interesting how all these groups have different priorities. And of course, for patients, their priority is their safety, strangely enough, and to have nurses that are knowledgeable and to have continuity of care. But again, thinking about 12-hour shifts, we know that that's not going to happen because we have data that says that with 12-hour shifts, continuity goes down, and also CPD is not possible. But again, there's so many different priorities at different levels, and sometimes it's so difficult to find ways to address it properly. So I think the future work that we need to do is to work collaboratively across these different levels of the organization. So that's really, I think, really important. And this is just a study that I'm about to actually wrap up. But I think it was an attempt, excuse me, it was really an attempt at starting to improve shift patterns for nurses. And we just finished collecting data for a DCE, a discrete choice experiment. So find compromises that nurses and trade-offs that nurses might be willing to make when it comes to shift patterns. So working shift patterns that might be not exactly what they wanted, but they might be more conducive to patient safety. But yeah, watch this space because I haven't got any data to present from these yet. But yeah, just as a final message, I think whatever direction, I think we're all stronger if we work together. So if any of you here is interested in this topic area and want to elaborate, I'd be really happy to hear from you, but also to hear your thoughts. For example, what do you think about these patient incidents, using patient incidents for research, or any other thoughts or questions or comments that you might have? I'd be delighted to take them. And thank you for listening.
Thank you very much, Chiara. That was really fascinating. So we have some time for questions, which is great. And we have got one in the chat. If anyone else has questions, please pop it in the chat and I can read it out. Or if you put your hand up, I'll come to you in order and you can give your questions straight to Chiara. So I might start with the one that's in the chat first. So Helen, I don't know whether you want to read your question out or whether you want me to read it. There's Helen's there, but Helen's put, is this the same or different across different staff groups? I know my night shifts used to be 16 hours as a diagnostic radiographer. Are newly qualified more likely to be involved in senior staff, or is this equal across teams? So I guess the first bit is about, is it similar across different staff groups? And as a doctor, I guess I'd be interested to know the answer to that as well from doctor perspective.
Sorry, do you mean the shift length?
Yeah, I think that's probably what Helen's asking is about, I guess.
Okay.
The things you've been talking about for nurses, are they similar for other staff groups? Yeah.
Yes, so I think no, they are different in different staff groups, and also the shift length itself is not the same for nurses across different organizations. I know, or even within the same organization. I know from our interviews, but also from surveys that we did more recently, that some nurses work 14.5-hour shifts, 15-hour shifts. So the variation is really there. There's a lot of it, yes. And then are newly qualified more likely to be involved than senior staff, or is it equal? Sorry, I don't know what that refers to, Ellen. If you could expand on it in the chat, it would be amazing.
I don't know whether it's about as people progress through levels within a certain staff group, whether things change in terms of staff, but I don't know. Maybe Helen can, if you put in some follow-up.
Oh yeah, okay. No, I see what you mean. Well, surely there's less flexibility, I think, the more you develop, I think, because for some roles the shift patterns are fixed, or also for some roles there needs to be at least one person of that band on that shift. So with a limited pool of people at that level, then your shift patterns are quite fixed. So I don't think necessarily that going up in grade leads to more flexibility and choice when it comes to shift patterns. But maybe this wasn't your question, so.
Thanks, Chiara. I've got a question from a colleague here who's watching. It's about, has it been looked at, the fatigue comparison between working 12-hour shifts for 3 days, say, versus longer runs of shorter shifts? So let's say you did 8 to 10 days, but 8-hour shifts. Has there been any comparison between that?
Yeah, no, that's a really interesting point, and not directly, but what now she's not a PhD student anymore. She just passed her Viva, but Talia Emanuel did some really interesting analysis looking at shift intensity. So not directly comparing 3 long shifts, like 3 consecutive long shifts versus 6 consecutive short shifts, but just the shift intensity, like how many shifts in a row were associated with sickness absence. And it was interesting because shift intensity did play a role, but again, it wasn't the kind of deal breaker when it came to sickness absence. So there was still that 12-hour shifts effect very much prominent in there. So, but yeah, no, it's a really valid point. I think it's all about how these shifts are planned and then of course deployed. So because working 10 short shifts is not going to be less fatiguing than working 3 long shifts, of course, but we need to remember that the sort of intershift recovery period is dramatically reduced. And something else that has been advocated as a positive of 12-hour shifts is that you can never have a quick return, because so having fewer than 11 hours between 2 shifts. But actually, if you think about it, like if you finish work at, say, 7:30, you have your handover, so you leave the hospital at around 8. And, by the time you get home, it's probably quite late. You need to have a shower, have some food, maybe have some social kind of conversations with someone. And then by the time you are back in the hospital at 7 a.m. the day after, that's really, it's less than 11 hours recovery, essentially. So I think even that assumption that you've got more intershift recovery with long shifts is not really realized, I would say.
Thanks, Chiara. Livy's got a question, I think.
Hi, thank you so much, Will. I couldn't put my hand up. Thank you so much for a great presentation. I didn't catch the beginning, but I'm so glad that I came into finding out your findings at the end. So I did a PhD, or I'm doing a PhD, looking at racialized incivility within maternity settings and kind of implications for the consequences on the individual, the work group, and patient safety. And I was really interested to see that there's incidents go up when you're doing longer shifts, because one of my findings was that there was unfair and disproportionate allocation of work, and harder, more complex patients were going towards more racially minoritized groups. But also we know that they are more disproportionately impacted by disciplinary procedures and having harder sanctions against them. So it was interesting to see the upstream kind of consequences of kind of recognizing that longer shifts and more intense shifts can lead to incidents. And I was just wondering whether that's something, when you said about kind of routinely collected data, I wondered whether like an equity focus might be there within like what you look at, and disciplinary proceedings perhaps might be a thing to look at.
Absolutely. No, that's a really important point, Olivia. Thanks for raising it. So we have never looked at disciplinary proceedings, actually, and I wonder where in hospital systems they would be collected, because they would probably be, well, I wonder if they might be in hospital systems, but they also might be outside of the hospital systems. And something that I think is really missing from our data so far is demographics. So ethnicity, age. I mean, in nurses, we know that 90% is female, but still, we don't have a lot of data around that. I mean, we collect some data on ethnicity in in our most recent survey, but in routinely collected data, because of really data access issues, we've never been able to collect it. So we were only able to look at just what the nurses worked, not at what kind of nurses were there, like in terms of age, ethnic groups, and even just years of experience, qualifications. So a lot of variables weren't actually there, which I recognize is problematic. But I also am very aware from conversations I've had, especially now that the NHS is relying a lot on internationally trained workforce members, and they're actively going abroad to recruit people. I know that these staff members who come in from abroad are, like you say, incredibly disadvantaged and offered shifts that are really appalling, like shift patterns that are really appalling. So definitely when you're talking about the those like effects that we see with 12-hour shifts, it might be because it's people who, like you're saying, that who are disadvantaged and are probably forced, or maybe not forced, maybe that's too strong of a word, but like are given shifts that are really disadvantageous for them.
Like a lack of power to be able to go against what their supervisors are saying.
Yes, absolutely.
Thank you.
Thank you, and good luck with your PhD.
Thanks, Chiara. I think that goes some way to answering Helen Cowan's second point, where I think what she's clarified is that she was asking about, difference between the level of experience of the nurse, I guess.
Okay.
But it sounds like you didn't have some of the data to answer that question. But
No. Thanks for clarifying, Ellen. No, we didn't have any. So we didn't know who, and if it was like a medication error, for example, we didn't know who made the error. It was just at a ward day level, like how many incidents happened, what type of incidents were there.
Yeah. I've got a question from Lauren, and then Ed, and then we'll come to Hannah, if that's all right. So, Lauren in our team was up. Thank you very much for a very interesting presentation. And she's asked, are we able to tell from the evidence which is the lesser of two evils for patient safety? Shorter shifts and more disruption to care continuity, or longer shifts and more fatigue?
Yeah, it's really difficult. I would say it really depends on what you mean by continuity, because it's true that you have fewer, like the patient can see fewer people during the day. But then A, when we asked nurses, is the continuity of care increased because you're working long shifts? They said no. And B, when you think about continuity as, for example, seeing the same healthcare professional, so nurse, doctor, more frequently during the week, that's a different side of the coin, isn't it? So it's a different aspect of continuity that you would be losing with 12-hour shifts. So, I mean, I think the ideal world would be one where you can work 8-hour shifts. I think 8-hour shifts are better for fatigue and also for some aspects of continuity, but I'm very aware, and I didn't really touch on this in this presentation because it was more about patient safety rather than workforce well-being, although in my world, the two are really connected. But of course, a lot of nurses not just want to work them, but need to work them because how they can organize their life around them. So it's a really tricky question to answer. And I mean, in an ideal world, 8-hour shifts would be much better, but I recognize there's so many different tensions at different levels that mean that it's not often the most feasible option.
Thanks, Chiara. And I know you mentioned, obviously, you're focusing on patient safety for this talk. Lauren also just asked about patient experience kind of metrics alongside those shift patterns. And I guess I'm thinking about also patient complaints and things like that. Would be interesting.
Yeah, that's actually a really good idea. Thanks for that, Lauren. Yes, because actually you could be not just focusing on incidents, but which are, after all, staff reported, but also looking at patient complaints. Yes, that's a really good idea.
Thanks, Carrie. Got lots of questions. So I'll go to Ed, and then I've got Hannah. I haven't forgotten about you. So Ed was just again saying, great presentation. In your work looking at shift patterns across different European sites, were there any countries demonstrating a better awareness of fatigue and patient safety? So I think Ed's thinking about, lessons to be learned from positive deviants, I guess, or places that are doing it better than us. So.
Yes. So, well, again, sadly, the work that we did with European data was a really, really large survey where we didn't have like an in-depth understanding of their systems in terms of like awareness of fatigue, risk management, and patient safety. So it was more a kind of nurses giving ratings of patient safety. But yes, I think definitely countries where and I know this not so much from this research, but because I collaborate with these countries, but countries where occupational health systems are much more advanced and, for example, routinely monitor burnout and fatigue exist. I would say mostly they are the Scandinavian countries, the Netherlands. They are much more proactive when it comes to fatigue, burnout measuring and monitoring. It's routinely part of their occupational health checks, and I'm afraid we don't have that here. So yes, there's definitely more awareness.
Thanks, Chiara. Right, I'll go to Hannah. Sorry for the wait.
That's all right. Thank you. That's very interesting to hear about. Just to follow up on Livy and your observation about the international trained professionals, I wonder how the culture they worked in previously influences their perception to what they can and cannot, ask for, or how the super nurse culture varies between that particular group and then the group trained in the UK. I don't think it's a question, it's just an observation to say it would be completely different, because I'm a clinician coming from a country that has a completely different healthcare system, and you get trained that you're not allowed to complain and you don't have any rights as a worker. So just be nice to see the difference between how the perception is for the professionals themselves upon their rights, and how that links with the fatigue and then the safety outcome, retention, satisfaction, and so on.
Yeah, no, it's a really valid point. Thank you. And I mean, myself, you can probably from my accent, I'm not from the UK. I trained as a registered nurse in another country too. And I think when I did my degree, it was a bit like you described, Anna. I think things are changing now because we see more and more internationally educated healthcare professionals who come here, but then after a few years they leave and go somewhere else. So yes, you're right. I think our culture might be, influencing the degree and the kind of things that we might be willing to accept, but up to a certain extent. I think enough is enough at some point for everyone. But yeah, thank you for that.
Thanks, Chiara. I think I can't see any more questions or hands up. So thank you very much for a fascinating seminar, and had lots of interesting questions. We will share the video recording, and we can share your contact details if you like, Chiara, if there's other people who'd like to get in touch with questions or, to talk about opportunity, I guess, to collaborate and things, if that's okay. Thank you very much again. And Sobia, do we know what could you remind me what the next seminar is?
Yes, it'll be in April now, and that's probably with Professor Peter Hibbett from the University of Macquarie from Australia.
Okay, great. Right, so with that, I think that's probably everything. So thanks a lot again, Chiara.
Thank you. Thank you, everyone. Bye-bye.